What do you do when you're not on the same page and you don't think you're going to get there?
Well, there are some people that come in with negative A breasts and want to be triple D. And they're just our limitations. And I'll tell them, I mean, there is only so much I can do to keep it a safe operation and a predictable one. The long-term studies show that really big augmentations require much more dissection. There's a higher chance of revision. There's higher chance of decreased sensitivity by affecting some of the nerve supply. And so we talk about that. And I've had a couple of people in my career that went as big as they could go from their negative A and then came back in 8, 10, 12 months and went the next level. So that's pretty extreme. That's not really happened very often. I try not to have that ever be in the operative plan, but I think that is the key to make sure that both the patient and I are on the same page, and that the patient has realistic expectations of what can technically be done.
How do you do sizing in your practice? What's that process look like?
Well, it's mostly interoperative. So, we talk about the measurements and such that I've made in the room, and we do reference sizes, bra cup sizes. But once I'm in the operating room with the patient, and I typically come with a range of implants, sometimes 3 or 4 different sizes, just so that I can factor in what I find intraoperatively with regard to what I was talking about earlier, the valves of the ribs, the pectoralis muscle tone, et cetera, et cetera. But I use an intraoperative sizer typically it's a saline adjustable sizer, and I put it in the pocket and kind of see what size gets me closest to the pictures that the patient's provided. And that's how I can very predictably make sure patients don't come back post-op and say, hey, I'm too big, hey, I'm too small. I don't want to ever hear that from a breast augmentation patient.
Are they trying something on at the consult when they're not with you, like when they're with the coordinator?
Not really. I've gotten away from trying to have them put a sizer implant in their bra. That's done all across the country. Maybe even most people do that. But I've just not really felt like that's the best way to do it. It takes a little more time in the operating room to use the sizer system. I think some doctors maybe just want to get through that a little bit faster, but this is a procedure that this patient's going to have forever. So I'll tell you, I never want to cut corners in the operating room. If it takes an extra 5 minutes to nail it, then I'm going to do that 100% of the time. And it really works. So it helps me to sleep better at night. It helps the patients to sleep better at night, and it helps keep them smiling when they come back post-op.
Do you take a photo in the OR to show them later?
Not really. Maybe sometimes when I do a breast lift with implants, the way I sequence that procedure in the operating room is that I'll do the breast lift first and then do the augmentation. So for example, if the nipple is below the fold under the breast, that there's a new repositioning that's necessary. So once I do the lift, then basically we're getting that augmentation as a primary augmentation, because the lift has already accomplished taking care of the ptosis or settling to the breast. And so sometimes I'll take a picture of that halfway through and keep it in the patient's file, but not typically,
Okay, give us your Instagram handle and your website.
drleebydaniel.com. We have a couple of other sites, but that'll direct you. And then Instagram handle is pretty easy to remember, Best Plastic Surgeon. So
That's you?
That's me.
I finally found him.